So my name is Kenneth Carter. I'm a clinical psychologist at Oxford College, which is a liberal arts intensive division of Emory University. And today I really want to focus most of my time on the changes between DSM-IV and DSM-5. I know a lot of people have been teaching in introductory psychology for a while and may be sort of daunted by these changes. And so what I thought I'd do today is to highlight the main changes between DSM-IV and DSM-5, and then we'll sort of open it up for questions. I'm going to focus mostly on the changes that are listed in the disorders that are listed in Learned Psychology, but also a couple of new conditions in the chapters that you probably teach. The American Psychiatric Association always wants me to make sure that you know that DSM-5 and DSM are registered trademarks of the American Psychological Association. We're going to discuss a little bit about the DSM-5 structure and the global changes. I'll hit some information on the psychotic disorders, the bipolar disorders, the depressive disorders, the anxiety disorders, the obsessive compulsive and related disorders, the trauma and stress-related disorders, the dissociative disorders, the somatic symptom and related disorders, and the personality disorders. You may notice some of these are new sections. For example, bipolar and depressive were in one chapter in DSM-IV, and these obsessive compulsive and trauma and stressor-related disorders have been peeled out from the larger category of anxiety disorders. But I'll mention that in those different sections that we get to today. First of all, DSM-5 is a really big deal because it's really the first major revision to the diagnostic manual in more than 30 years. The last update that we got was DSM-IV-TR, which is the text revision, which didn't really change any of the conditions. It just really updated the statistics. So it's really been since DSM-IV that we've had a major revision. One thing I wanted to point out, and I've seen this kind of slide in other textbooks before, which is this kind of thing, where you basically see that the number of disorders has increased and increased over time. And I added a little bit of an extra twist to this. And so what you'll see here on this side is the number of conditions in each of the DSMs. So, and then here on the other side, you'll see the number of pages that the DSM has. So DSM-1 has only about 106 conditions, and it had 130 pages to it. DSM-2, which still had sort of a psychoanalytic influence, had 182 conditions, and somehow they were able to fit it in only 4 more pages. DSM-3, which is a big revolution, changed over from a little paragraphs describing the conditions to more the structure we're familiar with today, ballooned to almost 500 pages. DSM-3R had only a couple more conditions, and they added some more description here. And as you see, what's been happening since DSM-3 is the page numbers increased, which to me means there's a lot more specificity in terms of what's going on in describing these conditions. Now, one thing you'll notice here about DSM-5, it has 262 conditions, and this comes out of the DSM-5 master class that I attended. And what you'll see here is, I know it looks like there are fewer conditions. 297 is a larger number than 262, but they're actually probably about the same number of conditions. What they've done is they've added more specifiers, and they've collapsed some things. And so it's really not really fewer conditions in DSM-5, and it weighs in a really heavy, nearly 1,000 pages. DSM-5 came out this May 20th of 2013. I remember because that was a couple of days after my birthday. It was my birthday present to myself. And it was built upon the perceived flaws of DSM-IV. First of all, diagnosis doesn't tell us a lot about severity or disability. If a person has, 3 symptoms of depression, they don't have depression. If they have 4 symptoms of depression, they don't have depression. All of a sudden, at 5 symptoms, they have depression. Even at 9 symptoms, they still have depression. And most conditions in the DSM don't give you any information about severity of the condition, and they've tried to fix that in DSM-5. Also, there are high rates of comorbidity for most of the conditions, and they want to address that. lots of rates of everyone's second favorite diagnosis, which is the not otherwise specified category. And the first one is adjustment disorders, of course. They really thought that having too many not specifying conditions was a problem, and they wanted to go back and see if we can really figure out what those conditions might be. Also, the DSM was starting to hinder the research process, and they wanted to really address the concerns of researchers in DSM-5. The DSM-5 had about 13 different work groups that worked on the different chapters of the DSM, and there was a work group chair, and the chair of the work groups created some guiding principles that they wanted the work groups to follow. First of all, they wanted to make sure to optimize clinical utility, making sure that the changes were going to be useful for clinicians when they're diagnosing their clients. Also, they wanted any changes to the DSM to be evidence-based. Now, that doesn't mean that the entire DSM is evidence-based, but really the changes between 4 and 5 were built upon some evidence. They wanted to make sure there was some continuity with previous editions. What they didn't want was someone to open up the DSM and have no idea what they were looking at. So they wanted to make sure that it was familiar looking to individuals. And this next one caused a little bit of trouble. The work group chair said there were no constraints on how different the DSM-5 could be from the DSM-TR. And so, to me, these two different things seem slightly at odds. So in some way they were saying, do whatever you think you need to do to get things right, as long as it's kind of like what we had before. And that created a lot of interesting media coverage about potential conditions, because this was also the first time that public comment was collected through their website. So you may have heard lots of rumors about different conditions that were going to be in DSM-5, and many of them didn't end up in there because they were operating under the assumption that there were no constraints on what they could do, and they published those new ideas on the website. They also want to emphasize lifespan development, and that's actually woven through the chapter sequence as well as the sequence of disorders within each chapter. Their big goal was to create a dimensional approach to the measurement of distress, disability, and severity, looking so that each disorder was on a continuum. So many conditions in DSM-5 have severity ratings of mild, moderate, severe, and some even extreme. They did it in a couple of chapters. They didn't do it with everything, but that was one of their big goals. They also want to incorporate more knowledge of risk factors for different conditions, prodromes, which are really red flags for certain disorders, and prevention strategies. So you'll see a lot more of that information in the main text of the DSM, where they'll even, for example, indicate which symptoms of a certain condition may show that a client is at a higher risk for suicide. So it's going to be very helpful for clinicians as they approach this. They also wanted the DSM to be a living document. They didn't want to wait 30 years before the next DSM, which is one of the reasons why they changed over from DSM-5 with the Roman numerals to the number 5. Future updates of the diagnostic manual are going to be called what I call software style. So the next DSM will be 5.1 until they make a major revision at DSM-6. One big global change that they made to the entire DSM is they changed the term general medical condition, which was woven throughout DSM, to another medical condition. So if you have a disorder that is created by a medical condition, like a depressive disorder due to DSM-IV, you would have said a general medical condition. In DSM-5, you would say another medical condition. So this is something that they've done. A lot of people feel like this is another nod towards the medical model. It's important to remember that the American Psychiatric Association was responsible for creating the DSM, so they're going to really approach things with that medical model in mind. One huge change that might be a relief to those of you who are teaching introductory psychology is they've actually gotten rid of the multi-axial system. So anyone who's tried to explain the 5 axes to students, a lot of times they don't understand why we've divided these conditions into 5 different divisions, and now we don't do it anymore. It's causing clinicians lots of consternation, but professors who teach this are cheering all throughout the world. First of all, there was no scientific reason for separating the disorders into different axes, and so what they've really done is combine axis 1, 2, 3, and 4 together. You may remember that axis 1 were the clinical disorders, axis 2 mostly consists of the personality disorders, axis 3 were those medical conditions, axis 4 are psychosocial stressors, and now these are really all on one line. I tell people DSM-IV had 5 cubbyholes, DSM-IV has 5 cubbyholes, DSM-5 just has one listing of all the conditions. There's now separate notation for what was in axis 4 and axis 5, but you should know the axis 5, which used to be the global assessment of functioning, is no more. So there's, instead of rating the individual, in terms of their severity, what we're doing now is really rating the severity of each condition. There are about 20 disorder chapters in the DSM. The number of disorders is about the same, but there are a couple of extra chapters that creates a little bit more specificity. So what I'm going to do now is to hit some of the chapters and talk about some of the main differences that you'll see from DSM-IV to DSM-5. We'll start off with the schizophrenia spectrum and other psychotic disorders. These conditions, as you know, are defined by abnormalities in delusions, which are false beliefs, hallucinations, which are sensory perceptions with no sensory input, disorganized thinking or speech, grossly disorganized or abnormal motor behaviors, including catatonia, and all those negative symptoms that you'll see in those conditions. The schizophrenic spectrum and psychotic disorders include schizotypal personality disorder, and you might be wondering what's this doing here. Aren't the personality disorders their own chapter? What they've done now in DSM-5 is they've cross-listed some personality disorders in certain chapters, so you'll see them pop up here and there. Delusional disorder is also here, psychotic disorder, schizophreniform disorder, schizoaffective, and schizophrenia. You may not cover all of these in intro psych. I only cover a couple to give students an idea of what these conditions address. One big difference in DSM-5 is that they really reduce the importance of the differentiation between bizarre and non-bizarre delusions, mostly because a lot of people had trouble distinguishing those bizarre from non-bizarre delusions. Bizarre delusions, as you know, are things that are not at all possible, and non-bizarre delusions are really unlikely, but possible, and they've actually made that not as important in DSM-5. One huge change they made in DSM-5 is that they have actually removed catatonia as one of the subtypes of schizophrenia. Because there are no more subtypes of schizophrenia. About 68% of people who were diagnosed with schizophrenia were diagnosed with the undifferentiated type anyway, and so they decided to get rid of those subtypes. What they've done with catatonia is they've actually made it a separate specifier. So an individual can be diagnosed with schizophrenia with a catatonic specifier, but this catatonia can actually be co-occurring with other conditions as well. Basically, it's mostly a descriptor for depressive conditions, bipolar, and psychotic conditions. You need about 3 symptoms to meet the diagnosis for that catatonia specifier. Some examples of those symptoms of catatonia include things like stupor, waxy flexibility, which is where a person can be posed and they remain in that state for a while, mutism, echolalia, which is a repetition of vocals, and echopraxia, which is a repetition of movement. Delusional disorder, DSM-IV, there was this huge distinction between that it had to be a non-bizarre delusion. In DSM-V, they've removed that requirement for the differentiation between those bizarre and non-bizarre delusions. But there is a separate specifier for individuals with delusional disorder that are bizarre. They've also removed shared delusional disorder, so any of you who have been teaching about folia do. It's no longer part of the DSM-5. For schizophrenia, like I mentioned before, the overall definition has not changed that dramatically. There are a couple of little tweaks in some of the conditions, but the big change is that the subtypes have been dropped. For the depressive disorders and bipolar and related disorders, the first thing you'll notice is that they've actually separated the chapter from talking about mood disorders into bipolar and depressive disorders. They're now separate categories. The bipolar conditions include things like bipolar 1, bipolar 2, and cyclothymic disorders. The depressive disorders include a couple of new things like disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder, which is basically dysthymia, and then premenstrual dysphoric disorder, which was in the appendix, but they moved it up to the main part of the book. One change in the bipolar conditions is that there's a lot more emphasis now in changes in activity and energy, and not just focused on elevated or expansive mood. So a clinician will look at whether or not a person's activity and energy have changed dramatically. Some people with bipolar conditions will not admit to having an elevated or expansive mood, but their activities are sort of indicative of that kind of change. There was a lot of talk about adding a new anxious distress condition that was different than major depressive disorder or bipolar. It had really, really bad inter-rater reliability in the field trials, and so what they did instead was they added what they call an anxious distress specifier. So individuals with lots of anxiety, in addition to a bipolar or a depressive condition, they can add this specifier to that condition. For major depressive disorder, the huge change in major depressive disorder has to do with the bereavement exclusion. So there have been no really big significant changes in the core criteria, but the biggest change is that you may remember in DSM-IV, if a person has a major depressive episode but they have a major loss in their lives, you wouldn't diagnose them with depression, you diagnose them with bereavement. They get to grieve for 2 months, and then they get diagnosed with depression if it continues after 2 months. Well, they've taken away that bereavement exclusion for a couple of reasons. Number one, the exclusion implies that bereavement only lasts for 2 months, and we know that grief can last for much longer than 2 months. Also, bereavement can be a severe precipitating event to depression. In fact, in DSM-IV, it was the only event that didn't count as an event towards depression. And bereavement-related depression is likely to occur for individuals with past histories of major depressive disorder. So if there's a client that has been depressed before, they have a major loss, it's likely to kick them into a depressive episode. Also, bereavement, we know that the things that we do to treat depression that's related to bereavement is pretty much the same kinds of things that we use to treat non-grief-related depression as well. I know a lot of people have been saying that removing this bereavement exclusion means that we're now pathologizing normal grief, and I kind of don't see it that way. The American Psychiatric Association says that you should consider the possibility that when a client has a significant loss, that it could actually be more than just bereavement. And so what they're doing is to say that you should look to see what's going on with that individual person. And the new DSM gives some guidance about how to differentiate grief from depression. For example, grief can subside over several weeks, and grief tends to come in waves. But they really emphasize that cultural factors should really be considered when trying to distinguish between the two. You may remember from DSM-IV dysthymia. That was that chronic major depressive condition. They changed the name to persistent depressive disorder in DSM-V. And it basically combines the features of a chronic major depressive disorder and what we knew before as dysthymia. That means you can meet the criteria by either meeting the old criteria for dysthymia, which is that 2 or more year period of a mild depression, or by an extended major depressive episode that lasts for more than 2 years. And this is different than a recurrent major depressive episode where a person gets depressed and then it's better again. Here is sort of an extended chronic depression. And in the DSM, there's a way that you can identify the difference between dysthymia and that extended depression. A huge change in the next section, you may remember the anxiety disorders was sort of a massive chapter in DSM-IV. They've busted up the category into about 3 different groups now. There's a category for anxiety disorders, there's a category for trauma and stress-related disorders, and the category for obsessive compulsive and related categories. Now, this causes a little bit of confusion, I think, because it makes it seem as though trauma conditions and obsessive compulsive conditions don't have any anxiety to them, and that's really not the case. The American Psychiatric Association says they group them in the same neighborhood because they all have anxiety, but that can sometimes be confusing. And so I call them the anxiety, trauma, and obsessive compulsive and related disorders as a sort of a super category of all of these conditions. For the anxiety disorders, what I sometimes call the classic anxiety disorders, where you see a lot of fear and anxiety in these conditions. These include things like separation anxiety and all of these kinds of conditions. I'm going to hit the main points that have changed in the conditions in this chapter. First of all, one big change that's kind of a global change to this chapter is that agoraphobia, social anxiety disorder, specific phobia don't require a person to admit or recognize their anxiety as excessive or unreasonable. This was a weird little thing in DSM-IV that said that the person basically had to say that their anxiety was more than it should be, and that's kind of hard to do, actually, because most people won't admit that. What they've done instead is to say that the anxiety has to be out of proportion to the actual danger, of course, after taking into account any cultural context factors. A little twist in agoraphobia is that in DSM-IV, it didn't specify the number of situations where a person had to have that agoraphobic avoidance. DSM-V says it has to be about 2 different situations, and the situations include things like public transportation, open spaces, enclosed places, crowds, or outside the home alone. And from my view, these kind of overlap a lot. For example, if you're in the subway, you're on public transportation in an enclosed place, and it's probably crowded, and you're outside the home alone. But I think what they're trying to do here is emphasize the difference between having avoidance of a certain situation versus this sort of global agoraphobic avoidance that you may have in multiple situations. One thing that I am so happy that they've done in DSM-V is that they've unlinked agoraphobia and panic disorder. Remember this chaos in DSM-IV? Panic disorder with agoraphobia without, I could never remember which one came first. And so what they've done is they've gotten rid of all of those, and they've left agoraphobia and panic disorder there. So you can either diagnose agoraphobia or panic disorder, or both. It's going to make it a lot easier for students to remember what's going on with these conditions in DSM-V. The core symptoms of those conditions that are remaining are pretty much the same. And actually, this is kind of neat. Panic attacks are now can be a specifier for many different conditions. So, for example, if you have an individual who has obsessive compulsive disorder but has panic attacks, clinicians can now add a panic attack specifier to that condition. Social anxiety disorder, I'm sure that's one of the conditions that many people teach about because it's pretty a common occurrence, and maybe even in some of your students. In DSM-IV, it was assumed that the social anxiety was a performance anxiety, and there was a special specifier you could add on for a person who has a generalized anxiety. The essential features of this condition are about the same. They deleted that idea that you have to recognize your fear as unreasonable. But what they've done that's kind of interesting is they've actually flipped it. So now it's assumed to be generalized. Social anxiety disorder is assumed to be generalized unless there's a performance-only specifier that's added on to that. And there's a lot of evidence that suggests that this performance anxiety is really distinct in terms of its etiology or cause, the age of onset, and the physiological and treatment response. For the obsessive compulsive and related disorders, these include things like OCD. Dysmorphic disorder has now been moved over to the section. Hoarding disorder has been added. Trichotillomania got a name change to something much easier to spell, which is hair pulling disorder. And they've added another difficult to spell and pronounce condition, which is excoriation disorder, which is a skin picking condition. They've added these insight specifiers to the OCD category so that individuals may actually have different levels of insight in terms of what's going on with them. A lot of students have always wondered where hoarding was in the DSM, and it actually wasn't anywhere mostly. A lot of clinicians who treat hoarding would diagnose people with OCD. So they've added a new condition of hoarding condition. There's a lot of evidence that hoarding can actually be really distinct from OCD and actually could really be a lot more common than OCD as well. These are for individuals who accumulate objects that would normally be discarded, such as stacks of newspapers or junk mail or broken items, or it could even be the obsessive collecting of items, such as fabric or scrap metal. The most important piece here is that the hoarding must substantially compromise the intended use of active living areas. So if you have a lot of stuff in your attic, don't worry, that doesn't count as hoarding. In fact, I've even heard the story about Demi Moore, who has a house that she bought for her doll collection. That doesn't count as hoarding because the house apparently is for the dolls and not for her. They haven't added a having a lot of money condition to DSM-5, but this is an important piece of that diagnosis that has to compromise the intended use of active living areas. About 2 to 6% prevalence in the United States and Europe for hoarding conditions. It's actually reported 3 times more often in adults aged 55 to 94 than adults aged 33 to 48. And there's a lot of evidence as a genetic component. About 50% of hoarders have a family member who also hoards. They've done some interesting twin studies with hoarding conditions. There are different specifiers for hoarding conditions. There's an excessive acquisition specifier for people who continue to buy more things and bring them into their house. And, of course, there's those insight specifiers. There are people who know that things aren't really the way they're supposed to be, or poor insight for people who say, well, I think there's a good path between this room to the other, or absent insight, where they don't understand why this is a problem, and there may even be some delusional beliefs that are associated with it. A new condition in DSM-5 is excoriation disorder. This is recurrent skin picking that results in skin lesions. The face, arms, and hands are the most common body areas to be picked, and people may use their fingers, pins, or other objects such as tweezers to pick at their skin. It's really a habit condition, which is why it's here. It requires repeated and failed attempts to decrease or stop the skin picking, and not very good control over these behaviors. Some people even find that they do it when they don't even realize they're picking at their skin. Relatively low prevalence, about 1.4%. 3 out of 4 people with excoriation conditions are women. It's not intentional mutilation. So, for example, you might know in borderline personality disorder, you may have some people who are cutting at their skin. It's not that, and it can't be intentional mutilation, and it can't be due to another condition like psychotic parasitosis, where a person might believe there's parasites under their skin, and they're scratching at their skin to get at the parasites. Again, think of it like a habit. We know there's a little bit of we get a little bit of a dopamine squirt when we groom ourselves, which is why people like picking their nose. And so think about it like that, but with these skin lesions. And so there's some treatments to help with that, including cognitive behavioral therapy techniques to help out with that. Medications like SSRIs or naltrexone can be helpful because they really reduce the amounts of dopamine that might cause that pleasurable sensation from that self-grooming. And habit reversal techniques can be helpful too by giving them something else to do other than picking at their skin. Trichotillomania gets a name change to hair pulling disorder, which I'm kind of disappointed because it always made me seem smart at parties when I use the word trichotillomania. But now it gets this new parenthetical name of hair pulling conditions. But this, the name change, of course, this happened. DSM-IV said that it had to be noticeable hair loss, and DSM-5 it doesn't really require that at all. And DSM-IV, there was a attention and gratification criteria that it had to be gratifying to pull at the hair, and that's been removed from DSM-5. Still relatively low prevalence, about 1 to 2% in the U.S., and the female to male ratio for hair pulling is now about 10 to 1. Body dysmorphic disorder. This was an interesting change. I never thought that body dysmorphic disorder belonged in the somatoform disorder category, and they've taken it out of that and put it to this new anxiety, obsessive compulsive and related disorders. And they've added some new criteria for the behaviors or mental acts that people do in response to these preoccupations, like, for example, excessive, like looking in mirrors or asking for reassurance or applying makeup are now some of those repetitive behaviors that make it an obsessive compulsive related category. They've added a new specifier for muscle dysmorphia. This is for people who believe that they're very, very thin, even though they may be bulked up with lots of muscles. An interesting specifier because people with that muscle dysmorphia type of BDD are at a higher risk for suicide attempts, and so it's important to be able to identify them. There are also insight specifiers and delusional belief specifiers for that as well. The trauma and stress-related disorders, for all of these conditions, there's a requirement for a traumatic or stressful situation for each of these conditions. These include things like reactive attachment disorder and disinhibited social engagement disorder, which were in the childhood section of the DSM-IV, acute stress disorder, post-traumatic stress disorder, and the adjustment disorders. Let's hit the highlights of some of these conditions. Like I mentioned before, for all of these disorders, an adverse event precedes the onset of the symptoms, and this is actually unique for this chapter. And it mostly consists of former anxiety disorder and adjustment disorder conditions. For post-traumatic stress disorder, this has been a big change in the definition of traumas, which I'll talk about in just a moment. So it now includes hearing of traumas. And in DSM-IV, there was this little phrase that said that a person had to respond to the trauma with helplessness, fear, or horror. They've actually removed that subjective reaction as an important aspect of the definition of trauma because a lot of people didn't respond in that way. First responders like fire or police or soldiers don't often respond with helplessness, fear, or horror. They're trained not to. You wouldn't want a fire person to arrive at your door being horrified about the fire. So they've actually removed that subjective reaction from the definition of trauma. And they've sort of shuffled around the symptom clusters of PTSD as well. So I'm sorry to say PTSD was always kind of a complicated condition anyway, and now it's a little bit different in DSM-5. They've created separate criteria for PTSD for children under 6 too. Now, in terms of the trauma, some interesting changes to the definition of trauma. Of course, a direct exposure to a trauma still counts as a trauma. Now, watching it occur to others still counts. I think that was also in DSM-IV. What's new is that learning that it happened to someone close to you, like a close family member or a friend, now counts as a trauma as well. In fact, but these learning that it happened to someone close to you is only when it's really violent and unexpected. Also new in DSM-5 is repeated exposure to details of a trauma can count as a trauma. They mainly intend this for first responders, such as fire, police, or soldiers, or even counselors who often hear about traumas over and over again. I did a DSM-5 presentation in New Orleans, and a lot of the counselors there said that they experienced what they called secondary PTSD from hearing about the traumas during Katrina, even though they weren't living in the affected areas. In DSM-5, these now count as traumas. One interesting little change that's kind of controversial is that it doesn't count for trauma if it's immediate exposure unless it's work-related. So if you're responsible for reviewing tapes where there's been a bomb or something and it's part of your job, that would count as a trauma. Or 911 operators, that would count as a trauma. But if you watch television coverage of an event, that doesn't count as a trauma according to the American Psychiatric Association. My thought is they're trying to make a distinction between traumas that are visited upon you, that you don't have a choice about, versus most non-work-related media exposure to traumatic events is really a choice of watching those things. Now, I don't think this means that people don't experience PTSD-like symptoms of that, but the American Psychiatric Association is saying that those things don't count as PTSD in their book, literally. Symptom clusters of PTSD are about a little bit of a change. They're intrusions, symptoms, avoidance symptoms. A new category are these alterations in cognition and mood, and also increased arousal and reactivity. Let's take a quick look at some of those symptoms. For those re-experiencing symptoms, basically what you're looking for here is one symptom of re-experiencing trauma. This can be memories of the traumatic event or dreams that can be distressing. People who have flashbacks, which is sort of a reliving of the traumatic experience, or psychological or physiological reactions to reminders of the trauma. For example, I had a client once that had a car accident near a grocery store. Whenever he was near that grocery store, he would feel afraid, which was a psychological reaction, or have increased heart rate, which would be that physiological reaction. For the avoidance symptoms, you need just one of these. These are situations that might elicit memories. So you're avoiding thinking about the trauma, or you avoid external reminders to those traumatic events. For alterations in cognition and mood, you need two of these. This is the most changed category in DSM-5. Maybe forgetting details of the trauma, that was in DSM-IV. Here's a new one: negative beliefs about yourself, other people, or the world, or distorted thoughts about the cause of the trauma. Now, these two symptoms, to me, represent the cognitive behavioral influence of the DSM. Looking at negative beliefs or distorted thoughts, one of the first times that these are highlighted in a diagnosis. In addition, negative emotional states that people might have, anhedonia, which is inability to experience pleasure, and detachment. You just need two of those. Increased arousal and reactivity. These include things like irritability, recklessness, hypervigilance, sleep problems, increased startle response, or decreased concentration. So some of these are kind of shuffled around. What's new are these symptoms of irritability and recklessness. Those weren't in DSM-IV. Another huge change is in acute stress disorder. Now, in DSM-IV, acute stress disorder was really just a shortened version of PTSD that went from about 3 to 30 days, and is now not just that shorter version of PTSD. The biggest change in acute stress disorder is that there are about 14 symptoms of acute stress disorder. A person has to have any 9 of them. What that means is that it's not going to necessarily automatically become PTSD on day 31 if they don't have those correct clusters that they need in order to meet the criteria for PTSD. So a person could have acute stress disorder up until day 30, and on day 31 they may end up with a not otherwise specified kind of condition. Everyone's favorite diagnosis for clinicians, the adjustment disorders, pretty much exactly the same in DSM-5. Now they're just a subsection of the trauma and stress-related conditions as opposed to being something all by themselves. Not a lot of big changes in the dissociative disorders. Those conditions include things like dissociative identity disorder, dissociative amnesia, and depersonalization and derealization disorders. Just a couple of little changes. They've added derealization to depersonalization disorder. Dissociative fugue is now a specifier of dissociative amnesia, not a disorder by itself. And they've actually expanded the criteria for DID so that it can be observed rather than just reported. That's kind of a new thing. A couple of big changes to the somatic symptom-related disorders, and I'll try to hit them pretty quickly. the big changes here, well, they've actually changed everything in what used to be called the somatoform disorders. And so I'll try to summarize the changes or these new conditions because they're, kind of new from what we've had before. One change here, you'll see that factitious disorder is now not its own chapter, but it's now in this new somatic symptom and related disorders family. For somatic symptom disorder, this is a person who has somatic complaints that cause disruptions in their family, cause disruptions themselves. The main focus of this has to do with their thoughts and feelings that are taking up a lot of time or causing anxiety. Has to last for at least 6 months, and adding this removes overlap and confusion with other conditions. The prevalence of this is kind of a broad range between 1 and about 20%, because they're still figuring out where it was going to go because it's a new condition in DSM-5. Psychological factors affecting other medical conditions. This occurs when a person does have medical symptoms that are present, and they're having these factors that are adversely influencing their symptoms. It could influence the onset or severity, or cause problems with treatment. And so, for example, I had a client who had HIV infection and couldn't swallow his pills. He thought they were poison, and he could swallow other pills, but not the medicine for his HIV condition. And so here, you see that a person would have these psychological factors affecting HIV infection. You can imagine that that could also be the case for any number of medical conditions. And so a psychologist may actually work with the patient around these psychological reasons to help them to improve those medical conditions. New thing in DSM-5 is illness anxiety disorder. So kind of a remake of hypochondriasis. This is preoccupation of having or getting a serious illness or anxiety about your health that creates these excessive health-related behaviors. And now you can have a care-seeking type or care-avoidant type. We usually thought about hypochondriasis as always involving care-seeking. But here, it's really, you can have a lot of avoidance of health care because the person's afraid they actually do have a certain condition. 1.3 to 10% prevalence for illness anxiety disorder. Factitious disorder, not a lot's changed with factitious disorder. It's now under the somatic symptom and related disorders family. The only little change really is that they used to be some factitious disorder and factitious disorder by proxy. No one could really remember or knew what the proxy was, and so they changed the name to factitious disorder imposed upon self and factitious disorder imposed on another. Now, some people know this as Munchausen's. Munchausen's is the International Classification of Diseases, or the ICD term, and factitious disorder is the DSM term. This is when you are intentionally producing or faking or over-exaggerating an illness in order to play the sick role. Really interesting story with the personality disorders. Basically, a huge revision was envisioned when the proposal was submitted to the American Psychiatric Association last December, December of 2013. It was deemed overly complex and it was rejected. So what they did was they moved that work into the appendix of the DSM for further study. And so the DSM-5 is going to use the DSM-IV system for personality disorders. In other words, the old gang is still here. All the conditions that you had in DSM-IV are now still in DSM-5. Only 3 things you need to know about personality disorders. Number 1, there are not access to conditions because there's no such thing as access to anymore. Second thing is that some of these conditions are cross-listed in different chapters. Like you saw that schizoid personality disorder, schizotypal was cross-listed under the schizophrenia spectrum conditions. And the third thing to know is that they've changed some of the not otherwise specified categories. Other than that, everything is exactly the same. The clusters are still there. The descriptions are exactly the same as they were in DSM-IV.